Good evening. My name is Jeff Apple. I'm the Travis County Medical Society President, and welcome. Thank you for coming tonight and attending this evening's Business of Medicine program. The title of our talk tonight and program is How We Serve the Underserved in Travis County. I frequently hear from the TCMS members lots of questions, especially this year with all the changes with the medical school, how we prepare and take care and organize the care of our indigent in our community, who its providers are, how or to what extent it is or isn't integrated or coordinated, and how or to what extent community physicians may participate in it. And that's a big question for a lot of our community members. Even with someone like myself, I've been here over 10 years, who works in the system, who takes care of the indigent, it's often very confusing. And a lot of people don't fully understand how our system works. So we've invited a panel of very select physicians and administrators and CEOs from all the different organizations that provide indigent care here in our community. It's a complex system. It involves government, private, nonprofit, and also academic at the UT Dell Medical School. I like to manage some expectations and kind of make it clear from the get-go. We won't have the time to go through everything tonight. What I would like tonight is a better understanding of our indigent care system, how it's administered, and how people can get involved. In other words, I want our presenters to provide clarity of language of what they do. It's going to be limited probably to a high-level overview of the many components of our indigent care system, and I hope you'll leave here at least with a better understanding of what they do. We're going to start with several short introductory presentations by panelists from 5 representative components of the system, and I think you'll know many of the names that are here. And then they'll be joined by 5 more members of other organizations in an interactive panel at the end. There's brief bios and short resumes of most of the members here that are at your table, so I won't take the time to introduce all of them, but I would like to recognize several of our presenters tonight. The first to my right is Dr. Mark Hernandez, a CMO at the Community Care Collaborative. Next to him is Dr. Alan Schalza, who's the Chief Medical Officer at the Community Care Clinics. Dr. Vicki Butler, the Chief Medical Officer at Lone Star Circle of Care. Dr. Melinda Lopez, Director of Reproductive Medicine at People's Community Clinic. Dr. Bill Turney, the founding director of the Dell Medical School Department of Population Health. Ileana Gilman, I don't think she made it. David Vanderstraten is going to fill in for El Buen Samaritano. He is the head of the Physician Advisory Board for El Buen. Marcy Rowe, the executive director of the Volunteer Healthcare Clinic. And Sylvia Munoz, the director of clinical services at Buen. Thank you. Kathy Gachenga, Director of Project Access for the Travis County Medical Society. And then Dr. Brian Sayers, who many of us know, he's the Medical Director for Project Access and a volunteer physician at the Volunteer Healthcare Clinic. I'd also like to recognize a special member and past president of our Travis County Medical Society, Dr. Pete Zamora. Pete, thank you for being here tonight. He's currently the chairperson of the Central Health Board of Managers. That's a very big role, and we're glad you're here, Pete. Thank you. There are note cards and pens at your table. Please fill those out with questions that you have and pass those down. Just put them at the bucket at the end of the table, and I'll review those, and when we do the interactive session, we'll present those. Now that no further delay, Dr. Hernandez will tee us up with a brief overview, organized healthcare arrangement for doctors. Thank you, Mark.
Howdy, everybody. Jeff, thanks for having me. Marshall, thanks for having me. I've got exactly 10 minutes. Let me set my timer. So I've got now less than 10 minutes to try to explain all of Travis County underserved care to you, which is a daunting task. But the truth is that every one of you out there has been part of this system for as long as you've been practicing in Travis County, and you already know that part. You know what parts you play in that. If you take care of hospitalized patients in Travis County, then you have taken care of some of the underserved because they go to hospitals, and at some point or another, somebody's called you to be involved in that. Some of you in your ambulatory practices have been involved in clinics that care for the underserved. Sometimes you've had individuals who are low income that have come to your practices. We've all been involved in the care of the underserved in Travis County for years, and you are the system, and we are the system that cares for this. That doesn't mean you understand it, and that's one of the challenges with healthcare is it's really incomprehensible, and the care of the underserved has often seemed incomprehensible. I'm going to try to shed a little bit of light on that for you. And I've got to give you a little bit of history. I'm going to go really fast. I'll gloss over a whole bunch of parts that most of you have been around longer than I have in Travis County. You know this story, so I'll go quick. To begin with, in the state of Texas, the care of the underserved is a county function. So counties are responsible for caring for their poor. But what a county is required to do is an abysmally small amount of care. So all that the state requires a county to do is care for its its residents who live at 21% or less of the federal poverty level. And it doesn't actually specify what amount of care those people should get. So the reality of it is, in most counties, there's just very little care that's provided to the very, very poor. And if you're just kind of poor, like 28% of the federal poverty level, you don't get anything, or you're not entitled to anything. And that's the way Texas has set up indigent care. Now, in urban counties in Texas, there was realizations back in the 50s and the 60s and the 70s that urban centers created concentrations of individuals who were poor and needed health care. And so in those sorts of urban counties, there began to be a push towards we need separate taxing authority to be able to pay for care, because we have so many individuals that we've got to care for that the normal healthcare system is not just able to stomach it. And so you saw the advent of county taxing districts. And all the big taxing districts in Texas for healthcare came about in the late 50s through the early 70s. Every one of those counties that has one created it then, except Travis. Travis County didn't do it then. There's a whole long story that goes about it. It goes all the way back into the 1800s and the way that the city got surveyed. I won't tell that whole story tonight. If you catch me later, I'll tell you what I know of it. But the reality of it is that what we ended up with in Travis County was the city was caring for the poor. The city ended up with the ownership of the hospital, and the city ended up providing that kind of essential care for the poor in Travis County. And because the city was doing it, the county had very little it needed to do, because the city had already kind of moved into that space. And so the city owned the hospital, the city operated it, the city owned a bunch of clinics, and they operated those clinics inside the city limits. And the county, for its part, ran clinics in the out-of-city portions of the county. So we've got some clinics that are way out in the outlying parts. Back in the day, they were truly out of the city limits. And that's the way healthcare was provided in Austin, Travis County for a good long time. What happened in 1995 was that the city realized it should not be operating a hospital, namely because it didn't really have the expertise to do that and keep itself solvent and keep its hospital solvent. And so it felt like it needed to do something different. It went into an arrangement with Seton Healthcare Family. And Seton was in town, was providing hospital services over at Seton Medical Center, and was looking for the opportunity to grow. And as its mission, as part of the Catholic identity of Seton, it wanted to care for the poor and vulnerable. Those things went together, and a deal got struck where Seton came in and began to operate Brackenridge Hospital on behalf of the city. And so in that deal, Seton then became contractually obligated to provide care to the poor and vulnerable as part of the arrangement that it made with the city of Austin at that time. Now, the city kept running its clinics. So the city maintained all of its clinics, was still operating, was still employing the docs and the nurses and everybody else. And that continued to be the way care was provided. Meanwhile, there's still lots of other sorts of charity care and underserved care that was happening that wasn't organized, that was done by different docs in different places. But the organized part of the system was essentially the city of Austin and Seton. That lasted until 2005, and if you were around in 2005, you'll remember that there was an election, And in that election, the Travis County Healthcare District was born. Actually, at the very beginning, I believe they called it the Hospital District. That election to create the hospital district occurred because really a perceived crisis in mental health services. There was not enough mental health services being provided in the county, and there was a push and an impetus to really figure out this problem. And remember, we didn't have a healthcare district here because we'd never had one. And so suddenly in 2005, we're bringing a proposition to the voters to say, create a healthcare district so that we have more dollars to be able to care for people in this county, and the voters created it. So we ended up with a hospital district, now known as Central Health. I won't go through those manipulations, but today we call that entity Central Health. That entity immediately then inherited the hospital, the clinics, both from the city and the county. So the city and the county both saw an opportunity at that point to move those sorts of the operations over to the new healthcare district, because we now had a taxing entity that could care for that population. It all came over to Central Health. And Central Health had to make a decision kind of right then, which was, are we going to be a care provider or are we going to be a payer? They made a decision to be a payer, a taxing entity that was going to put money into the healthcare economy. And so they spun off all of the clinics as a separate entity, today known as Community Care. And you're going to hear from Alan Schulsha in just a minute, who represents that organization today. In 2013, so now shooting up eight more years, in 2013, Seton and Central Health got back together and realized that the model that they had to provide care to the poor and indigent in Travis County wasn't working as designed. That there was too much separation of the ambulatory part and the hospital part, and we weren't providing as much specialty care as we really needed for that population, and that something had to give. Meanwhile, there were big changes occurring. A medical school was being talked about being built. The 1115 waiver, a different way for a state to receive its Medicaid funds, was occurring at that same time. And mixed into all these changes, Seton and Central Health decided to go into business together in a different way. Not as landlord-renter, which had been the relationship between the two entities since forever, and now to be partners in a new organization. And this new organization is called the Community Care Collaborative. I'm lucky enough to be the chief medical officer of that organization. I've been doing that for about the last 5 years. What are we about? We essentially are the entity that now owns both the clinical and the fiscal responsibility, the risk, so to speak, for the underserved in Travis County, which is about 100,000 people. We essentially receive dollars from both of our parent companies, Seton, now Ascension, Texas, but same company. We receive direct dollars from them. We receive direct dollars from Central Health, so tax dollars. And then we earn money via the 1115 waiver, which represents about 40% of our dollars that we draw down from the federal government. We have an annual budget of about $142 million a year, and we purchase care for the uninsured. That is the job of the CCC. So if you've ever heard of MAP, and I know that you all have, and have ever wondered, what is MAP? Is MAP insurance? What is this? MAP is a benefit program. That benefit program, for individuals who qualify for that benefit program, MAP pays for certain services for them to receive. We are the payers of MAP. My organization is the one that actually pays for care from MAP. But understand that Seton still today continues to retain an obligation for the provision of large parts of the care. So there is part of it that we pay for. For example, if a patient needs to go out and get a primary care visit at any one of my colleagues' clinics, we pay them for that. We have a contract with them, and we pay them an encounter rate for those visits. If my time is up, I'm going to go real quick. But if, for example, that patient actually needed to receive a gallbladder surgery, they would be admitted into a Seton facility, and Seton would be financially at risk for the provision of that service. They're responsible for the facility fees, and they're responsible for the physician fees that come with that. We're going to let our colleagues or my colleagues get up here and talk a little bit about their parts of the system. I expect that we'll have a robust conversation once this part is over and we get to the panels. So thank you very much. All right.
Thank you, Mark. That's a lot of ground to cover in 10 minutes, I know. So that's a big organization. There'll be lots of questions at the end for him. Thank you. That was a good summation. Next speaker will be Alan Schalza, the Chief Medical Officer at Community Healthcare Clinics.
All right. Good evening. Thanks for the opportunity to share a little bit of information about the under-resourced. As Mark said, community care has been around for about 50 years, and we became a federally qualified health center in the early 2000s. And what that basically entailed is we receive a small amount of federal funds. We have to report more than any. We report a lot of data. And we're mandated to care for anybody who walks through our doors. At the same time, we have the opportunity to afford care to individuals who are under-resourced, and specifically one of the aspects within FQHC, Federally Qualified Health Center, that benefits patients that are under-resourced is our pharmacy program. So other than the VA, within our environments, we can afford meds at a cheaper or less expensive rate than in other environments. With federally qualified health centers, really concentrate on primary care. So within community care, whether it's family medicine, pediatrics, OB-GYN, internal medicine, that's where the mass of our concentration of providers are. We do house specialty care within our walls. Some are employed and some are contracted. Community care last year saw about 100,000 unique patients. We have about 25 clinics, 30 if you consider our mobile clinics. It's a lot of people. The irony is I think there are 100,000 or more individuals that need access to care that have no access to care within Travis County. So though we and our partners are seeing a ton of folks, the need is immense. Within community care, we offer care to those folks who have diagnosis with HIV, and we're part of the national leaders as far as HIV care. Those who are experiencing homelessness are also an aspect of our care model. I think working with our partners is the only way that we're going to achieve success and move patient care forward. One of the things that Mark really talked about is the fact that we contract together. And as strange as it may seem, I think for the under-resourced patients, we actually at times can offer a better model of care than with a third-party payer. Mark and I can sit in a room and we can say, is the most efficient manner of care for a provider, for a doc, to see the patient, or could a nurse visit count as a patient care visit? Could an MA visit count? Can we empower our dietitians and our pharmacists? Can we create efficiency so by the time the patient gets back to see the physician or the advanced practice provider, the metrics, the quality metrics have improved because there have been so many hands in improving that care that we've advanced it. And so in many ways, the under-resourced who do gain access to care, their metrics actually surpass our third-party payers because we can contract in an atypical way. It's a huge advantage within our environments. And I think I'll stop there. Thank you for your time.
Thank you, Alan. That was very, very, very nice. Third speaker tonight will be Melinda Lopez of the People's Community Clinic. You probably know some of Melinda's writing. She writes a lot on human trafficking, is an expert, I think, in the Austin area on that, and we're excited to hear her story. Thanks, Melinda.
Okay, thank you. Don't know how much of a story I have to give. I'm here on behalf of our CMO, Louis Appel. I'm an OBGYN, and I'm one of the newer directors in our clinic system. I'm director of reproductive health. So People's Community Clinic has been around since the 1970s. It was first opened by a group of volunteer physicians in a basement of a church downtown in Austin, and it's since grown quite dramatically over the past few years. We're on track to see about 17,000 patients in 2018. We are also a federally qualified health center, so most of what you just heard about federally qualified health centers and kind of the patients we see and the services we offer applies to us as well. We have 4 different departments. We have a pediatric department, adolescent health department, reproductive health, and adult medicine departments. Within those departments, we have specialists and primary care providers. We also have consulting specialists, such as cardiologists and other services that are available to our patients. We do see any patient that walks through the door, funded or unfunded. We accept most Medicaid, Medicare, and Marketplace plans. There is a sliding scale fee for patients based on what their income level is. We do have a pretty robust behavioral health care system in our clinic, and we have lots of social workers who staff our clinics pretty much anytime there's a clinic that's open, so we have access to their services throughout the week. I think that's all I got.
Thank you, Melinda. Our next speaker is going to be Dr. Butler from Lone Star Circle of Care to tell us about their mission up north. Thank you.
Thanks for the opportunity to be here. So Lone Star Circle of Care is also an FQHC, like you've already heard. We are based in Williamson County, but we have some clinics down in Travis County. We've been around since about 2001, where we started as sort of a grassroots, community-based provider volunteering time kind of clinic. And about 2002, we became an FQHC, and we've grown. We sort of waxed and waned through the years. We've expanded into 5 counties and we will be opening our 19th location before the end of the year. For Travis County, we have a clinic that's more recently opened. It's Collinfield, and it's one that we're doing some special projects with Dell Medical School. Dr. Brandon Allport is here, and he is the one of the family providers who's there. We'll be working on some of those projects. We also have Ben White Clinic, which is family primarily, but it also has a number of behavioral health providers who are there, including psychiatrists and therapists, and they're available to provide services to our patients. Because we're an FQHC and we have underfunded, underinsured patients, we have some other services that are available throughout the other parts of our system. We too have additional services that are available where we can refer patients within the system should we need to do that. The services we can provide, though, we certainly do. We have MAP patients who come down to our Ben White Clinic. We have a number of those. We've added a retinal camera so that we can do some imaging that goes back to our optometrist to read those to know whether we need to refer patients out for other exams and additional services. We also have a clinic that is pediatric. It's on Stasny. And in about January, we'll be adding dental services there in an agreement with MAP and a contract where we'll take care of MAP patients there with our dentist, provide services that they might not otherwise have. So sort of an overview as we go down the table, but those are the kind of services we provide. It's primary care services, family, pediatrics, behavioral health, which is really, really nice for us to have in-house, including psychiatrists, like I said, which sometimes are hard to find. And then we have OBGYN services, full scope, in some of our other clinics that are available for us to refer our patients into should we need to do that. And we have internal medicine down at Ben White, in addition to the services I already talked to you about. And that's, that's pretty much what we do. Our patients, we call them our mission patients. The providers we hire are ones who express an interest to work with that type of patient because, you've seen the patients in your office yourself, and they can be difficult because they frequently don't have resources. And sometimes we as providers look at our patients and say, grief, and just be compliant. We have outcomes metrics we have to meet. The payers expect us to hit certain numbers, and we have to be able to produce good outcomes. And one of the good things about FQHCs for you, if you're in a private practice and you have some of those patients, we're here to take those patients and provide care for them if you can't, because in private practice a lot of times you're limited to how much unfunded care or low-income care you can actually provide. And so we are happy, all of us are happy to assist you with that if you need to. If you have patients who need services where they can't maybe otherwise get those, please be happy to send them to us, and we'll do everything we can to help. We do take commercial insurance too, but it's a small amount of what we do is for patients that choose to come to us. But primarily it's underfunded and underserved patients. And that's pretty much all I have for Lone Star, and we'll be happy to answer questions in a few minutes if you have some. Thank you.
Thank you, Dr. Butler. Our next speaker is Dr. Bill Turney from UT Dell Medical School, the School of Population Health.
So in many ways, I'm the oddball here. Not only am I the academician, but they all work for large healthcare providers, and that's the one thing that Dell Medical School is not. The primary care division is in my Department of Population Health, and we have opened one clinic. It has 3 part-time physicians in it. It's going to see 1,800 patients, and they mostly have insurance. So we're not participating in what we're talking about much today if it's what we're building and running. But that's not why we're here. So we partner with community care. So why do we need patients? Well, how do you train physicians without patients? So the clinical environment is our classrooms for teaching. And the other thing we're committed to is trying to come up with new models of care that are hopefully cheaper, better, and more fun to work in. So how do we do that? Well, we do that, first of all, and we have a commitment to the underserved. So how do we do that? Well, we partner with these guys. And so we've co-hired with community care. Alan is a member of my department. We both provide care. We have faculty providing care in his clinics, and we also have medical students, residents being trained in those clinics. We, as Vicki mentioned, we have partnered with them they bought the Collinfield Clinic specifically as a laboratory for us to design and implement value-based models of care, because they're really good at the fee-for-service game. They're really good at it. And they think it's going away. They don't know what to replace it with. And so they said, if we provide you with a clinic as a laboratory creating a model of care, will you work with us on that? So we hired Brandon to come in from Hopkins with a med-peds background to be able to be the anchor physician in that clinic. And I'll get back to that in a second. But then with Peoples, that's also a place where we educate medical students and residents, and not just my department, but also in women's health, in pediatrics, and in some of the other specialties. So it's our role to help you imagine. So imagine a clinical environment where as a physician, I practiced for 25 years on the Q15-minute treadmill. It wasn't a whole lot of fun. Imagine a clinic environment where I saw a patient an hour. But that patient needed an hour because the patient was complex, was acutely ill, or just out of the hospital or whatever. And the people who needed less sophisticated care could be cared for by people who were practicing at the top of their license. We call that task shift. In a global environment, we call that task shifting, where everybody isn't seen by a physician every visit, because for the more routine stuff, it's actually been pretty well demonstrated much of the time. Healthcare providers of other backgrounds can actually provide better care. So let us focus on what we do best and let them focus on what they do best. And sometimes, maybe not even in the healthcare environment at all, maybe in the home. I mean, think about how many patients come in. About a third of my patients come in for blood pressure checks. Think of all the things that go through with, travel, waiting rooms, screaming kids, everything. They come in and get a blood pressure, and so that's supposed to indicate how they are 24 hours a day at home? Why not measure it at home? So imagine an environment where and I have to look at Mark, new methods of funding, because fee-for-service incentivizes utilization. So new methods of funding that rewarded you for avoiding unnecessary care and avoiding bad outcomes, and using that to reinforce programs that actually help people get and stay healthy. So that's healthcare. Healthcare predicts about 16% of health outcomes. Your clinical environment, your living environment predicts about another 3%. So 81% is due to either your social environment or the decisions you make, whether you smoke, whether you drink, whether you ride your bike without a helmet, whether you try to run when you're 60 years old and tear your Achilles tendon. And we pay very little attention to that. Sometimes the behavioral health stuff or the preventive care stuff, we tell people not to smoke, but we pay very little attention to that. So imagine an environment where a clinic, an FQHC, is an anchor institution for health in the neighborhood in which it sits. And that the people working in that clinic take responsibility for that neighborhood, regardless of where people are going for care. Although, admittedly, most people in low-income neighborhoods will be coming in there for care. So imagine them knocking door to door and assessing health needs and meeting them. If they're clinical, then meet them through the clinical system, navigating through the health system, using the community health workers that are gathering this information. But if you don't have a safe place to rest your head at night, nothing else matters. And that's actually been shown in the recent Medicaid experiments, where if they've taken Medicaid dollars and invested them in housing people, called Housing First, it's actually cost less money in health, combining that and health care is less than not housing. It costs less than not housing them at all. The Kaiser Permanente group showed, it was Geisinger, they have a thing called the pharmacy with an F, where they write food prescriptions and give diabetics food and show they're lowering their cost of caring for diabetes by giving them free food. So if we can extend the notion of health care to caring for people's health, and realizing that 80% of that are things that happen outside, are not measured by the blood pressure cuff or what comes out of a needle and things like that, but are measured by people's social, economic environments, et cetera, their zip code rather than their genetic code. Those are things we actually can't do something about, but we haven't been trained as physicians to do it, so we punt it. We punt it to other social service agencies, et cetera, but I don't think we should have to do that. And if with the right kind of funding scheme, we get rewarded for caring for those things so people don't get sick in the first place, that's, for us, the target we're aiming for. And so we're starting out small, a single clinic that Brandon is anchoring and a single FQHC network. But Lone Star has 19 FQHCs, 19 other FQHCs. And they said, if that model works there, we want to disseminate it. In fact, they're already planning to do one in a new one they're building in Taylor. So this is an opportunity for us and you all to be able to say, in a small way, can we demonstrate models of care that get outside the box of the every 15-minute primary care treadmill? And if so, can we show that it actually works and that it's actually scalable? And honestly, I don't know the answer to that question, but we're going to find out. Thanks.
Thank you, Dr. Tierney. Guys, thank you, Mark, Alan, Vicki, Melinda, and Bill for those very informative short surveys. Let's take about a 2-minute stretch, get something to drink, and then we're going to jump right into the interactive session. We got lots of questions. I have some will prompt a lot of good discussion here. So we'll be back in about 2 minutes here. Okay, so we have a lot of good questions, and what we'll do, I want to start off with Alan. What is a patient-centered medical home? In simple English, meaning I can understand it.
All right, am I turned on? So patient-centered medical home,
I think there's a designation as far as kind of a reimbursement source, and then there is the actual ability to ensure that no patient care is dropped. So referrals are tracked, imaging is tracked, handoffs are made between, referral, between all parties that touch the patient care. And in theory, the patient is at the center and all other aspects transition in order to facilitate that care.
Mark, can you explain the 1115 waiver from Medicaid and what that means to the amount of money coming into the CCC?
Yeah, and I'll try to do this quickly because we could spend all evening talking about the 1115 waiver. So basically, a state receives its Medicaid funds through a section of the Social Security Code, which happens to be a section 1115. So at one point in the past, this is how the number got associated with that, just so you'll know. So at some point, CMS decided that they would allow states to apply for a waiver of that section. And if they granted that state a waiver, then it could receive its Medicaid dollars differently. It didn't change how many dollars the state would receive. It just meant they could draw the money down differently. And the way they would draw that down was negotiated between the state and CMS. When Texas got its first waiver back in 2011, the waiver that was negotiated between Texas and CMS was there would be a menu of projects that each performing provider could actually perform, and if they were successful in performing those projects, they could get paid to do it. Now, I offer up, this was not grant money. What they did was they took all the Medicaid dollars for the state, which used to always, for the most part, went to a program called uncompensated care. Hospitals received those dollars. And they took that bucket of money called uncompensated care and they split it. And they said, okay, this uncompensated care pool, the hospitals can still split that up, but there's less in it. Over here is now the new DSRIP. You may have heard that term before, Delivery System Reform Incentive Payments. We just call it DSRIP. In this DSRIP bucket, this is this project money. So if you didn't perform projects, you didn't get any access to this money. Hospitals came out on the wrong end of this, so hospitals really needed to perform these projects if they wanted to get their monies back. Basically, you have to perform these projects, and these projects really had to create better health in people. And it was a 5-year project. And by the way, it wasn't a grant, so you had to do the project first and be successful, or with your money, and if you failed, you didn't get paid. But if you succeeded, you'd get your money back plus more. There was a big match associated with the money you'd already spent, but you had to be successful first. So there was a element of risk associated with this program. How much money did it mean? For the CCC, my organization was a performing provider. Over the course of the 6 years of the initial waiver, it was a 5-year waiver, and then they added a year because the feds couldn't figure out what they were doing. So they added an extra year to it while they were figuring it out. We drew down about $250 million over that 6-year period. That went directly into our budget that we then turned around and purchased care with. For the state, the number was, I think, somewhere around $13 billion. Understand, however, those dollars were spread up by region, and how much money a particular region got was based on the population of that region. So the region that includes Harris County received by far a bigger share than other regions. Ours was a 6-county region that is all the surrounding counties for Travis except for Williamson. Williamson was in a different region than Travis was. That's my short version of DSRIP. I'm happy to, or 1115 waiver.
Thank you, Mark. So, Vicki, I'm looking at, you look at all the organizations in Travis County. You have People's Volunteer Healthcare Clinic, Lone Star. Community Care is obviously the biggest, most diverse. There's about 150,000 uninsured and a little bit more underserved. if you have all these organizations, why do we still have trouble? What's kind of the hang up or limiting factor for those in need to get to these, clinics? Because there seems like there's a fair amount of good clinics in Austin. Now, the East Austin area I know is kind of a new area that we're tackling with new clinics, but kind of what are your thoughts on that?
I think some of it has to do with transportation. Patients have to be able to get to those services. And a lot of the population we're talking about is somewhat limited in the area that they can traverse. I mean, we don't have as many homeless in our organization as maybe community care does, maybe People's. I'm not sure what their demographics are exactly. But sometimes one of the biggest things we hear is transportation. So one of the things that we're doing, and I know some of the others have thought about or are trying, are some transportation vouchers, so the patients can actually get to those clinics where they need to get those services. Even when they come in, sometimes for the primary care services, they get referred out. When they get referred out, they still have to have transportation to get to those, to the specialist, when we can find specialists who will actually be able to afford to take care of those patients. So that's part of it. It's just getting to the services that are there, even though they seem like they're really close to us. I mean, we can go hop in our cars and get there. We don't have to worry about gas money. We don't have to worry about, whether our car's going to start. We don't have those kinds of issues. So that's one of the big things that we've talked about. The other thing is funding from the patients themselves. They don't sometimes understand that they actually have these services available. So one of the things that we all do is we provide financial screening, benefits programs, so that patients can bring in their proof of income and those kind of things, the number of people in their family, so we can see where they are in terms of the federal poverty levels, and set them up with programs like whether it's MAP, whether it's signing them up for Medicaid or something like that, helping them be able to get those kinds of services that they wouldn't otherwise know that are available for them.
What, Melinda, what draws people to People's Community Clinic? What kind of patients do y'all seek out? Y'all see about 20,000 patient visits plus or minus a year.
Yeah.
Community, I think y'all see about 150,000 visits, something like that.
Yeah.
But I mean, People's has a large. What's your typical patient?
Yeah, around 80% of our patients are Hispanic, Spanish speaking or bilingual. So that's definitely one of our primary demographics. We have been talking more recently about trying to broaden our outreach efforts and reach out to other communities, and there's different ways to do that, but that's who we're currently seeing. Most people live in the downtown or central Austin area, but we do have folks coming from outlying counties too who are still driving to see us.
Okay. David, I know El Buen, kind of its mission originally was to protect those patients from Latin America having language barriers. Can y'all tell us a little bit about El Buen, its mission, and kind of where y'all fit in with the indigent care here in Austin? Or Silly?
I guess our mission focuses around providing healthcare services and other services to the Latino community. We probably 95% of our patients are Spanish speaking only. All our providers are bilingual, so our services are given in Spanish. Everything we do, we are able to communicate through our providers and behavioral health specialists. We also have education classes for ESL programs, computer literacy, and those are both covered in English and Spanish. So our campus consists of the clinic, and we also have an education building where they offer all those services. We also have a food pantry, and 95% of our patients live below the poverty level. A lot of them are undocumented and have a lot of other challenges other than just thinking about their health care. So at our clinic, we're able to provide a broad range of services. We have primary care at through the lifespan, including prenatal care. We have a very good behavioral health program. We have 6 providers and then 3 IBH specialists and a telepsychiatry service that sees some of our patients for complicated needs related to mental health.
So, I mean, just listening to you guys, it sounds like a lot of your patients are kind of neighborhood related, maybe ethnic or where they came from, and just tend to favor a certain clinic. Is that correct? You agree?
I think the fact that they come in and everybody speaks their language is a big reason why their patients keep coming back, and then word of mouth. So they know that if they come to our clinic, they'll have somebody that can communicate with them effectively.
This question just came in, and I think it's very pertinent, and it was probably pertinent 2 years ago, based on some information you all gave out. Have changes to our current immigration policies impacted care to the medically underserved? And feel free, any of y'all, to comment.
I'm sure I share similar experiences here on the panel, but we definitely saw an increase in our no-show rate. And when we started probing that a little bit more to see why patients were coming in, was it transportation issues, was it something else? It was concern about just being interrogated by ICE, or maybe they're being arraigned at our clinic, because we do see so many Latino patients. We do work with attorneys in our office. We have a medical legal partnership, and we try to address some of those concerns. So those services are available to our patients. But I personally, as a provider, I see patients, if not on a daily basis, at least multiple times a week, who are either in the middle of immigration proceedings or they have a partner who was deported, and it's incredibly stressful for our patients. It takes quite a toll.
Another question we have concerning, and this may be for Dr. Tierney or Mark, Central Health and Seton, kind of the alliance, the Community Care Collaborative. Where does the medical school fit in this model, and specifically specialty care, specialty surgical care, probably relating to how is it funded, how do people get involved, and so forth?
I'm probably not the right person to answer that question, although Carl knows a lot more about it than I do, because he runs our musculoskeletal care unit. But I guess I want to answer that by kind of going back to the question you asked Vicki, because I think it tails into that. That the reason why the underserved continue to be underserved, a couple reasons for that. One is that when you're low income, you don't come in if you're not sick, okay? And when you get sick, you don't have a source of care, because you haven't been coming to somebody for health maintenance the way that you do and I do, et cetera. They don't have somebody they can identify with. So that's been one problem why there are people who are underserved, despite the fact there are people willing to serve them. The second thing is that there actually is pretty good primary care coverage in this town. Try to get a referral to a specialist. The average length of time in community care, and correct me if I'm wrong, Alan, to go see a cardiologist is 14 months.
Wow.
It was 14 months for hip and knee arthritis, referrals to orthopedists, and they got it down to, was it 3 weeks now? Is that 1 week? But had to go through 2,600 patients to do it. So part of what we're doing is trying to, can we identify ways of whittling that down by identifying the people who truly need to see a specialist. I mean, many times, somebody's being referred to a specialist probably could be managed with the right kind of advice in primary care without having to go through all the hassles of getting into a specialist, if a specialist is willing to see somebody for the compensation they get. So that's one thing. But the second thing is that if you're only paid to operate, do stuff like that, you're going to operate. But if you can if we can establish a model of care where you're paid for the outcome-based care that the MSK unit is the initial one for, then you actually make more money by operating less, and your outcomes are better if you can operate on the people who are in the best shape and the best candidates for the surgery, and you weed out the people who can get better with less aggressive forms of care like physical therapy, et cetera, or the right medications. I don't know, Carl, you want to comment on that? Or? And as far as how it's paid for, et cetera, he's involved in those clinics, I'm not, so.
Yeah, I would ask Mark to help me with that as well. I mean, I think the bottom line is collaboration and partnership. So, I mean, I really look at the work that we've been able to accomplish is everyone in the community has helped be part of it. And I think we're going to the Lavery back there who was doing this long before I came to town in terms of taking care of this population in orthopedics.
So, well, one thing, like, to the layman, I would think, community care is affiliated loosely with Seton, I would think, and you have a Seton cardiology group.
Yes.
Why would it take so long to get somebody into a cardiologist? Do they go outside of the Seton system or so forth, or why would it take 14 months to see a cardiologist?
So let me take a swing at that one.
Yeah.
Given that the CCC is essentially, I set myself up earlier in this talk by saying that the CCC owns the clinical and financial responsibility for this population. So I take that question to be directed at me, and so I'll address it. Historically, for this community, we've not provided enough access to specialty care, regardless of which specialty you're talking about. And that wasn't about the fact that there weren't doctors whose jobs involved taking care of this population. I see Dr. Hill back there, and Dr. Hill, I worked with Dr. Hill when I was a resident, actually, and as part of the Brackenridge Specialty Clinics. I mean, there have always been doctors in this community that have been caring for the indigent in this community. We've never provided enough of that service historically, and that's largely been limited by money. Let's just be straight and talk about it out loud. It makes the conversation go faster and better. There's never been enough money in the system to ensure that everybody got care in an adequate fashion. And so what we've tended to do is use the hospital as a surrogate for the provision of specialty care. So there's too many primary care doctors in this community who can look into their own history and know that they told a patient to go to the emergency room out of frustration that they couldn't get the patient in to see a specialist, and finally reached their limit of that and said, I am worried about this patient, and the only thing I can do is tell them to go to the emergency room because I think that will actually get them some attention from a specialist, and nothing else I've tried has worked. And so that has been the state of specialty care. It's been provided to this population for a long time. It was certainly what I inherited in 2013. And in some ways, we've gotten better. It is no longer 14 months to see a cardiologist because we have done a lot of work to improve that. It isn't, however, a week like we've gotten in musculoskeletal, but it's much better than 14 months. But we still have this fundamental problem that because we don't have enough supply and because we haven't managed the demand, we have a mismatch, and that mismatch means you have lines. And then we end up talking about lines, and people who are sitting in line don't want to wait. And we had a situation in this county for a long time where there were no new patients seen in rheumatology for probably a year and a half. So the only way you got to see a rheumatologist is if you got sick enough that you ended up in an emergency room and the rheumatologist got called. Otherwise, you didn't get to see the rheumatologist. None of us should believe that that's the way this should be. And so what we have to do is we have to begin to create models, because guess what? My budget is relatively fixed. I don't get big infusions beyond what I've got to pay for the care. So what we are obliged to do, because there's no other choice, is we have to find different ways to pay for the care and encourage guys like my colleagues all the way down the line here to think of different ways of providing the care that allows you as an organization to remain solvent and maybe even make margin on what I'm going to pay you for providing those services. But we need to talk about different ways of providing the services. So we've got a big e-consult piece of work that's coming where basically those of you who are specialists out there will understand this better than anybody. How many times have you been in a doctor's dining room at a hospital and somebody walked up and said, hey, can I ask you a question? And then they proceeded to talk to you about a patient. And what you did is you told them, well, Mark, do this. And let me know how that goes. And if it turns out like this, you don't need me at all. And otherwise, do this. And if it turns out this way, call me back. And then I say, oh, thanks a lot. And I walk off and I go do what you asked me to do. And if it works out, you never hear from me again. And if it doesn't work out, I call you, and then you come and formally consult, and a transaction occurs. And you help me take care of my patient. Well, that's great in hospitals. We don't have a dining room for the safety net for every primary care doctor to go get their lunchtime question answered. So what we're going to do is we're going to create that electronic lunchroom. We're going to create the ways for primary care doctors to ask their question of the specialist. And by the way, we're going to pay the specialist. I mean, you didn't get paid in the lunchroom, you did it because you were nice and because you were my friend. But in this case, we should pay you to provide us some official advice on what we should do with that patient. And that advice is going to either be, one, do this and we're good. Two, do this and let me know. Or three, I need to see that patient. Can we go ahead and just have them come see me? Okay, then let's get that arranged. And let's quit having big lines of people who just need a question answered, because that's what we've done. So that's one of the ways we want to manage demand. We fundamentally have to change the way that we've decided to provide specialty care. We can't afford to do it in the ways that we currently provide specialty care. So in a world of straight fee-for-service, you do something, you get paid for it, that's the only transactional model. We don't have the additional dollars necessary to take care of everybody we got to take care of. So we've got to talk about different models of doing that. Sorry, I got a little carried away, but.
Can I touch on a phase in between?
Absolutely, absolutely.
Based on the fact that we do need to be creative, one of the aspects or one of the things that we've done within our environment is we've trained primary care providers, whether it's HIV, whether it's Hep C, whether it's rheumatology, on some of the basic conditions. And we've utilized the knowledge base of the specialists to train those aspects within primary care, and that diversifies their panel within the day. And initially, patients are referred to them, and then if they can't care for them, they're referred to specialists. So we've at least expanded our access to specialty without utilizing specialty while we're working on e-consults.
So you started not you personally, Mark, but the Community Care Collaborative was 2013, I believe. We have multiple different organizations. How do we prove that we're doing good, Dr. Tierney? How do we know that the health of Austin is better? The Austin Public Health Department, that came up with a, report and plans. And so what are the metrics that we're going to use to say we're doing a good job taking care of our underserved?
Well, there's some standard metrics, the ones you've seen, the longevity, et cetera, cost of care, et cetera. But I'm going to say something. I'm propose something a little more radical than that. The city of Santa Monica in 2015 got $1 million from Bloomberg to develop this thing called a well-being index. And it was essentially to measure the well-being in a scientific sample of the people who lived in the city of Santa Monica. And then it had 8 different subcategories. And I can't go into all the details, but some had it was economics, how happy you were, how safe you felt, whether or not you had. I don't know. I don't recall all the parameters, but every budget in the city has to be focused on one or more of those scales within the well-being index that it's going to make better. And if it doesn't make it better, the budget gets zeroed out. And they've been doing this now for 3 years, and they've been able to move the needle on this because it measures not only sickness but wellness. Because if you measure what's happening in the healthcare system, you're only measuring the people who are sick. And sometimes when you provide access to care, actually people who've been needing care come in, and you look like you're making people sicker by giving them access to care. Some randomized controlled trials of primary care have actually shown that they look like that it was harming people because people were showing up who had a pre-existing need. So and we're actually going to try to do this in the Runberg area. You don't know this yet. In the Runberg area, and then propose it to the city to measure this in like a 5% sample on a regular basis on every subpopulation, not just the poor people, because other people have needs as well, and see if a city government, the main reason it exists is to enhance the welfare of the people who live in the city. And if you're not measuring their well-being, you aren't making it better. And so I'm proposing, I mean, it's a little radical, I'm proposing that we actually should measure what we want to know and do it in a way that's not terribly expensive, but allows you to take all the money you're spending and get the best value for it. So otherwise we're going to be measuring what we measured before, which is utilization, essentially, and population level outcomes such as longevity, which is hard, it takes a long time to move the needle on longevity, right? It's going to take decades. You don't know whether or not the change you made yesterday is actually helping. So let's measure something that actually is subject, or it does measure acute change, and they've actually shown this in Santa Monica, which is a 250,000 people live in the city. It's not a tiny city. So I would argue that if you want to know something, measure it. And I think that this is a town that ought to take that approach.
Do you think the problem, I mean, what I'm hearing is food pantries, gardens, green space, and things like that. It sounds like a lot of these issues with indigent care are not doctor and nursing problems. They're societal problems, obviously, we know that. You're seeing the churches get more involved, the Episcopal Foundation supporting El Buen and all that. Do you think that's really going to be the answer to all this as far as cost saving and all that is?
I don't think there is an answer. I think
Uh-huh.
there's a whole ton of answers. I think this is a team sport.
Right.
And I think that if it becomes a community effort, that each one of these things is an asset, that ought to see what part of the problem are they trying to fix. And with enough of both the goodwill of the people who are working hard, but also how the city and county are investing their money and doing that wisely, I think you can make a difference. And none of these things is sufficient alone, but together I think they can, if in an orchestrated way, make a difference. I wouldn't be here, and I don't think many of us wouldn't be here if that we didn't think it was the case.
Sylvia, I got a question. If you live in East Austin, that's clearly what they call the Eastern Crescent, the highest risk population for the upcoming years for Austin and Travis County. What is the first area that they're going to come in contact with the care that they need? Where are they going to go? Are they going to go to their doctor, or are they going to first go to the emergency room? How does that happen? Someone's new to Austin, they live in East Austin, they don't have a doctor.
I mean, I think that everybody that comes in within that group, if they come into the area, they already know somebody that lives here. And so I think that's how we see the patients, because usually it's like, oh, well, we see families. And so usually we'll see the mom and the dad, and then we see the aunt. I mean, we see all kinds of, we see grandparents, so they just know. And when people move into Austin, they know that El Buen offers these services, that they're low cost. They don't need to have a social security number to come into our clinic. And so for the most part, we sometimes see very sick patients that walk into our door, and they need hospital care, and they're like,
Which hospital do they go to?
usually if they're, we have a lot of our patients go to the South Austin Hospital because we're south. And it's far, especially considering traffic in Austin, for somebody to have to drive from Slaughter, William Cannon, all the way down here. It's complicated, plus they don't have good transportation. A lot of our patients ride the bus, walk. And so they use, I think South Austin, they see a lot of our patients there.
Do most of your patients have cell phones?
They do have cell phones.
Why do we have an information problem then? Why do these people can't figure out where to go in this day and age? I know y'all thought about this a lot, but give me your thoughts on that.
I think this speaks to a large percentage of the population of patients seen in the FQHC world as well as the non-FQHC. I mean, folks have to work. They've got the cell phone, but if they're not working, they're not going to get paid. So we can have all the access, both primary care and maybe specialty, but if they're not working, they can't access those services. So again, to Mark's point, when we think about new and different model ways to provide care, it's how can we engage patients and families in school systems, for instance, or in grocery stores, or after hours. Heaven forbid we extend hours or be available on the weekends when school is not open, so that families could access care. And those I think are some of the solutions that we as a community need to consider, need to continue to consider.
I know that volunteer healthcare clinic establishes an after hours so people can work. They don't have insurance. They come in late in the evenings, which is a great idea. Even in the insured world, it's hard to find good after hours care. Are y'all's patients, meaning the indigent or underserved, are they showing up at these urgent care clinics on I-35 and all that? Or where are y'all directing them after hours? I'm assuming the clinics are closed, People's and community care. You can't stay open all night. Or where do y'all send them?
We have an after-hours clinic open till 8:30 on 4 of the weekdays.
Till when, 8:30?
8:30.
Okay.
Yeah.
Al?
So they're utilizing the clinics when they're there. I think so to touch on a couple aspects, Going back to cell phones, patients do have cell phones. I think health literacy is a problem. So I think we have 42 different languages coming through community care. And so even if you speak to them in their, in their initial, their original language, I think the understanding of what you're trying to say is difficult for them. There's still an access problem. So if you want to look at third next available, depending on what metric you want to look at, some of the clinics have, 5 weeks out for a new patient visit. And so there's between 80 and 100,000 people that have no access to care, and many of them are using the emergency department as kind of a last resort. If they are acutely ill, they won't go seek care. So by the time they get to the ED, it's more of an advanced disease because they don't have, as Dr. Tierney was saying, they don't have preventative care.
What, go ahead.
Several of our clinics, including Den White, has evening hours, and we have half a day on Saturday. So we do have some after hours available for Lone Star patients.
And just real quick, the CCC in the last year expanded the number of urgent cares in which we contract for MAP patients from 3 different, one urgent care company that had 3 facilities to 4 different urgent care companies, and now about 20 facilities available for Travis County. So besides what our partners here offer in their own expanded clinics and extended hours, we've contracted with 4 different urgent care companies where we pay for care for MAP patients, out of the notion that a lot of people go to emergency rooms for things that could easily been handled in an urgent care. They wait a really long time in an emergency room waiting room for something that you walk into an urgent care and 30 minutes later you're walking back out. And it, by the way, that costs the system a lot less for us to pay for an urgent care visit than for the system to incur an emergency room visit. And so we expanded the network for that.
One of the questions we have is, what is the advantage of being in an FQHC in addition to the pharmacy benefits? And the second part of that question, how come specialty care has not been covered of the FQHC? Almost every clinic for the underserved serves primary care. Anybody?
I'm going to jump in real quick on the specialty part and then turn it over to my colleagues to talk about the rest of the question. So specialty care in FQHCs is an interesting animal because the HRSA regulations in FQHCs limit certain specialties to being either in scope or out of scope. For the most part, it breaks down around surgical specialties and non-surgical specialties. So if you're a surgical specialty, you can't be in scope in a federally qualified health center. So we can't use FQHCs to run general surgery clinics because they're not in scope for FQHCs. Cardiology is. You can run that in scope. And so basically, we do have specialties embedded inside of FQHCs. Today, it is the ones that can actually land in scope in the FQHCs that we have pursued first. And we've added a lot of specialties to FQHCs since I've been doing this work 5 years ago. And I think we've got a lot more specialties that we're going to try to get into FQHCs before we're done, because there's still a bunch we haven't tapped yet. There's still a lot of opportunity left. But we're working on that. That is a valid strategy that we are pursuing.
Touch on some of the benefits within an FQHC environment. So we're mandated to see anybody who walks through the door. Some of the benefits are pharmacy-based, but if somebody doesn't have a payer source and they don't have MAP, there's a sliding fee scale which will be organized based on the patient's ability, or based on the patient's earning ability and the patient's ability to pay. So everybody should be able to access care. And then some of the advantages are really this wrapped care that everybody's been talking about. Because we have alternative payment sources, care coordination, risk stratification of patients, we're actually able to afford higher risk patients a collaborative team approach, and lower risk patients will get more of your stereotypical provider-patient relationship. But access to behavioral health and nutrition or pharmacy, I think, are some of the aspects that are afforded within an FQ environment.
For Dr. Hernandez, how is the MAP program supposed to work, and how is it actually working?
Well, that's an easy one. Let me knock that one out. How's it supposed to work? You know, I'm going to give you the quick down and dirty on MAP. There's a bunch of little rules that you don't care about, so I'm not going to worry about the little rules. I'll just give you the big ones. So MAP is a program that is aimed at individuals that are residents of Travis County, so you got to have an address in Travis County, and you live at 100% or less of the federal poverty level. That's the income limit that's associated with MAP. Now, we'll offer that today. One quick caveat: if you are undocumented, but you are a Travis County resident, the levels are a little bit different. For you, you don't qualify for MAP. You have to be below 50% of the federal poverty level unless you have 2 or more chronic conditions.
Can you give us some numbers? Y'all know
So
the FPL.
today, if we took a snapshot of the number of people who have MAP today, it's 28,000 people. If we took not a snapshot, but if I told you at the end of the year how many people have had MAP over the course of a year, the number is somewhere between 45 and 48,000. And the reason for that is right now you get your MAP and you have it for 6 months and you have to renew it. And so what will happen over the course of the year is some people will drop off of MAP, either because they just forget to re-up, or because they actually become insured, or they leave Travis County, and then others will come on. And so if we just look at it in terms of how many people had MAP over the course of the year, it's about 40, like I say, 45 to 48,000. We are going to be bringing, I probably shouldn't be talking about this, except it's a done deal, so I'll go ahead and talk about it. We're actually creating a new program called MAP Basic. That'll come out later in the next few months, and we're working with our partner organizations to implement that, so that's why I don't have a hard and fast date on when we'll do that. But MAP Basic, what that program does is it will take everybody from 101% of the federal poverty level to 200% of the federal poverty level, and it will provide them the MAP pharmacy benefit as well as access to the MAP urgent care network. Now, that might seem a little odd. Why are we just adding those two things? It's really because we want to make those individuals, we, the CCC, need to have a relationship with those people. And in order to have a relationship with them, we need to prospectively enroll them into a program that we sponsor. And there's no reason for them to sign up for it if there's not something in it for them. And really what those people need more than anything else is they need access to pharmaceuticals. Because right now, they don't get a pharmacy benefit through us. And so if you have somebody that's at 101% of the federal poverty level and has a seizure disorder and is on expensive anti-seizure medications, we don't help pay for those for them. The FQ might, but we don't. Well, we actually think we should be helping pay for those people to have their medicines so that they can have them because they will be healthier for having had their meds. We also want them to be able to access the urgent care network because that population actually overutilizes the emergency department more than MAP people do. And so that's the new program that's coming. Does MAP work as well as it could? Well, I don't know. The ideal would be that we would offer MAP to everyone up to 200% of the federal poverty level at a minimum. Why don't we do that? We don't have enough money. We don't have enough money to offer that level of benefit to everybody in the population who would qualify at this moment. And so we have added kind of phased increases to MAP so that we can get more people some sort of benefit. But the ideal goal, hopefully inside of the next 4 or 5 years, is to get everybody at 200% up to a full MAP benefit. That's certainly where we're aiming as an organization.
Thank you. All right, here's a question. Where does Project Access, part of the Travis County Medical Society, it's one of their programs, fit in, especially specialty consultations? Dr. Sayers or Kathy?
I'll jump in and then I'll share it with
Both
with
feel
Dr.
free to talk.
This is your program. Project Access was started in 2001, was the inception of the idea. Saw our first patient in 2002. And really, as I look around, I'm seeing the doctors who actually see patients on a specialty basis. So I was talking to Austin Gastro, does a lot of the gastro needs that they have. We do cardiology. Dr. Toby sees a number of ENT patients. And Dr. Sayers, of course, sees his rheumatology patients that come through. We actually provide specialty to all these clinics. It is open to all these clinics sitting on the panel. So if they have a patient that meets criteria, and we do not take MAP because it's funded, but it's anybody from that 101% onto 200. So that would be somebody making, a single person would be $1,000 on the low end, gross income to about 2,000 would make the 200%. And so they have access to specialty based on that. And it involves actually setting up the appointment, having the patient go to the appointment, and then any surgical needs are taken care of by both hospital systems have been amazing, the St. David system and the Seton system. And we've got some surgery centers, so the Northwest, the Medical Park, and all those guys.
So Project Access essentially acts kind of like a navigator
It sure is.
for certain people, the working poor, uninsured, those who don't have Medicaid, et cetera.
Yes.
Correct? Kind of just
No commercial insurance, just the underserved, between 100 to 200%.
those physicians donate their services free of charge. And your funding, where does the funding come from for Project Access?
From Dr. Mark Hernandez.
The Community Care Club? Okay. Has the Central Health District maintained mental health services a top priority? This is Dr. Adair, one of our local psychiatrists.
So that's a great question. Central Health, before the CCC even came into being, so prior to 2013, Central Health allocated a big chunk of money, $8 million a year, which it's continued to fund. That money is now in the CCC's budget, but essentially it's given to us through Central Health, so we're still spending Central Health's money on that deal. But we've had an $8 million budget item, and Central Health had it before us, to pay for inpatient hospitalization of individuals experiencing a mental health crisis. And today the CCC administers that. We actually then farm that money out to Integral Care, because Integral Care has some of their own dollars to pay for additional hospital beds, and they're in a better position to actually be the manager, the bed manager for that. And so they actually put that, the Central Health $8 million that we hand them, plus their own state funds, into the economy to make sure that people get a bed in a psychiatric facility when they need it. They contract with both Shoal Creek, but also with private psychiatric facilities here in Travis County. And I'm very proud of that particular work, because we moved away from a bed day rate, which is what we had historically had, and moved towards a episode of care rate, which has actually improved some of the healthcare outcomes that we've tracked with those patients while decreasing length of stay. And has created more economy. This year, we're actually letting some more of those dollars be flexible to be able to use some of the new sites that have come up in Travis County, like the Herman Center, and some of the other services that are now available that weren't available way back when, because frankly, if a person doesn't need to be hospitalized for their mental health crisis but can get intensive outpatient care or have a short stay somewhere, that's better. It's not only better for the patient, it's cheaper for the system. We can make those dollars go further. Central Health, and now the CCC, has always funded behavioral health through its contracts with all of the federally qualified health centers. So all of the FQHCs provide different levels and manner of behavioral health care to their patients. They do that through employing LPCs and social workers, and for Lone Star directly employing psychiatrists. And some of our other organizations like Community Care have a contract with Integral Care to get psychiatry services for those patients that need it. That's built into our base services agreements with those organizations. So could there be more of it? Sure. But for those patients who have access to the safety net system, I'm pretty confident that those people get the behavioral health services that they need. I would say Central Health's commitment to that has always been strong, and we continue it. Yeah, so Integral Care has, as part of actually DSRIP, I think originally, and then it's continued on, this mobile crisis outreach team. And there's been different versions of that, but essentially it's the notion that there are teams that are available at integral care places. Some of them are in conjunction with Austin Police Department to essentially, when a person is in crisis, what generally happens to a person involving a behavioral health crisis, particularly if you backed up 5 years, is that person ended up in one of two places: jail, because they were acting bizarrely, and the police got called and they picked them up and arrested them and took them to jail. Or the police said, I don't want to take this person to jail. I think there's something wrong with them. And they took them to a hospital and dropped them off at the emergency room of the hospital. And then the hospital ended up admitting them or watching them in the ER. And by the way, none of our big hospitals are really set up to care for an individual having a mental health crisis. I mean, they can do it. There's ED docs down there. There's nurses and things. But those aren't psychiatric facilities. They're not set up to really provide the care that those folks need. MCOT was kind of an in-between notion that we should put mental health professionals in the field that can interact with those individuals on the spot, often being dispatched by the same police dispatcher that sent the police car there, so that they can rapidly figure out, does this person actually do they need to go to jail? In most cases, no. Do they need to go to the hospital? In most cases, no, at least not Old Brackenridge or New Del Seton or Big St. David's. What they needed to do was go to the psychiatric emergency department. Or now that's actually embedded in Del Seton. Or maybe they need to go to the Guy Herman Center. Or there are other places that can help care for that person. And now we can make a decision in the field by a trained healthcare professional who deals with individuals in crisis, who can make a decision. The right place for this person is here. Let's not take them to jail, and let's not take them to the emergency department. Let's take them where they can get the best help. And so thanks, Pete, for reminding me about that.
Okay, so this is a great question. Do you, the leader of these multiple organizations, come together, leaders, in a collaborative effort to discuss resources, equipment, uncovered regions, etc.? I'm not from Texas. This seems very fractured and inefficient. Dr. Tierney?
So there's an organization that's run by Central Health called the East Side Healthcare Coalition, where everybody at the table is represented at those monthly meetings. And that's exactly what's discussed there. Does that fix all the problems? No, because the problem is not enough dollars chasing too many patients or people who are yet to be patients. But these conversations go on and they talk exactly about where is their need. So, for example, you mentioned earlier, a lot of the clinics serving the East Side, if you look at a map of those, they're all clustered along I-35. And so there have been discussions over the past 6 to 9 months of building new clinics in Del Valley and in Colony Park. And enormous conversation about that. Conversations about housing the homeless and things like that. About rerouting bus routes and using smaller buses and things, because Cap Metro is also coming to those. Austin Public Health is coming there. There are actually a couple of city councilors who come. So that's a venue for that. Could it be better? Sure, but you know it's the CEOs of these organizations that are coming there. It's Alan's boss and Mark's boss and Regina comes there and Rhonda Munhank, et cetera. So there actually is a forum for that. It's been happening since before I got here in 2016. It's actually been invigorated recently by more people being asked to join it. And it's beginning to, because I've seen, development of these things that happened in East Austin weren't there a year ago. There's now a clinic open next to the county jail on, what's that road in Del Valley? 925 or something like that. That's now open a couple days a week and can refer to the Southeast Health and Wellness Center. So there are actually solutions being made within that group. At the same time, the city is you've heard that they're planning this purpose-built community called in Colony Park. It's going to have 3,000 units in it. 10,000 people living there, and they're building health care into that and discussing that within this venue. So yeah, there is a venue for discussing this, but it's invisible to people who aren't participating in it until you see the things cropping out like these new healthcare centers. Mark, you know.
And the only comment I would add, thanks for that, Bill, because that was exactly right. But I would offer that if you used to own 10 or 15 years ago an old Windows-based computer, every once in a while the memory would begin to jam up and you'd realize you had to defragment your drive if you remember that particular owner's task. Because everything got on there in a confusing manner, and then you had to tell the computer to reorganize the entire memory so that it would be efficient again. The healthcare delivery system for the poor in Travis County has never been efficient. It has been fragmented and broken up for a really long time. So the defragmentation of this system is going to take a while. So I do offer that. I understand. I've been doing this work for about 5 years now. I'm still a practicing doc at Del Seton, so I still see hospital patients at Del Seton now. And I do that because I'm reminded every time I go into the hospital and take care of hospital patients how much work we still have to do. I'm never without a story or two to tell when I go back to my day job about how the system has not yet figured out how to do this as well as it should. And I know that all of you out there know that every day because you see it in your real lives. And I see it when I go, put my white coat on and do that as well. It's going to take a while to defragment it. It is fractured. So whoever asked the question, you got it exactly right. I got no dispute with you. It will take all of us to help put it into order. And that's really what we've been trying to do and what we continue to do.
Okay. We got med school financing questions. I knew they were coming, so let's just tackle some of them. How has the 100 million plus from the med school financing, so forth, increased access to care and quality of care for the underserved in Central Texas? Anybody?
I mean, I'll take an initial swing at that for sure. So, when we, and just so everybody's aware, again, for full clarity, though, if you read the paper or whatever, you can find all this stuff out yourself. But there's a three-way agreement that lives between the CCC, Central Health, and the Dell Medical School. That's the agreement. And essentially, the CCC makes a payment to the medical school on an annual basis. And Central Health is on that arrangement because they're really the parent company that pushed for the arrangement and they negotiated it. And those dollars essentially helped create the ability for the medical school to be formed. It was the public contribution, so to speak, to help the medical school actually be created here. So at the very beginning of this, I distinctly remember that a payment was made, and as I looked around to see where the med school is, they were telling me that Clay was being hired. And so, what I would argue is I had no expectations for the med school doing anything for me at that moment, given that the dean was being recruited. And that after the dean's recruitment, we would see rapid growth of the medical school. But, in terms of, what services are they going to provide for me, that was not on my mind. This was an investment in creating an organization that was going to help us do a bunch of things. And amongst the first things that the medical school has done that have, to me, more than proven the value of the organization is they brought thought partners to the problem of how are we going to care for the poor and indigent. We had been doing this, all of us here in this community, for years and years and years, and yet we hadn't figured it out, and the wait lines were long, and there wasn't any more money. So I had lots of people who would tell me, well, Mark, just pay for more. And my comment then, just like my comment now is I don't have any more money. We don't hold money back in our budget. We spend it all every year. So we're putting it all out into the economy, but in the way that care is delivered today, there's not enough money. We need new and different ways of providing the care in order for these dollars to stretch. And really, I needed thought partners to help me think through that. I never thought when I took the CMO job that I was going to figure out how to do it. I thought it was my job to round up as many smarter people than me in the community and have them help me think through how to do this. We've done that in myriad ways. One of them who just walked out was Carl Koenig, who has really helped us solve our problems as it relates to joint disease, musculoskeletal care. I am currently in conversations with Mike Pignone in the medicine department on how we're going to solve a variety of issues that involve patients in different departments inside the medicine department. I'm having conversations with Jane, the new ophthalmology chair, on how she's going to help me. I see Jack sitting here too. How we're going to restructure and rethink eye care for this population. Dr. Wong is here. There's a better way to do it. And with the help of these individuals, we're going to figure out the better way to do it. Now, in terms of services provided, as clinical services have begun to be provided by the medical school, we have taken advantage of the fact that clinical services are being provided by the medical school, and that's been a good thing, and we continue to expand our efforts to get our patients being seen by UT Health Austin providers. And that's still not enough. So I will tell you, I'm not looking just for the medical school to solve all my problems. I would love for them to solve all my problems, Bill. If you can get them all solved for me tonight, that'd be great.
So
But what I'd say is that I am looking to all of you. So our organization has signed more agreements with non-safety net providers, i.e. providers that never had contractual relationships with any of the safety net entities this year and last year than we've ever done before. And we continue to expand in that space because I want to partner with anybody who wants to partner with me, who wants to help me. But understand that what we're buying is value. I'm not buying services. I'm buying value. And if you want to help me, figure out better, more efficient ways to care for patients, I'll partner with you. And I'm anxious to have conversations with you. If all you want to do is fee for service and you don't want to send me any data back and you just want to just get paid for doing this and don't bother me with that reporting stuff, and no, I don't have time to sit with you and talk about how we can do this more efficiently, then I respect what you're doing and I hope you keep doing it, but that's not what we're trying to do. What we're trying to do is really improve the health of the population, and we believe we best get to that by working with people to create value for this population. And so the med school has been a very willing partner, as all of these folks up here with the various clinic organizations have been willing to go with us down that value conversation. But we're looking for others. If others want to involve themselves in a value conversation, look me up. I'm in the directory. We can have a chat.
Yeah, just briefly, the frustration has been more of time than money. Because, 2012, we've got a Prop 1 passed. 2014, we've got a dean hired. 2016, he's hired half his department chairs. 2018, I've just this past couple of months finished hiring most of the last people I'm going to hire. So we haven't spent most of that money because we haven't had people to spend it on. We haven't had boots on the ground, and that's and as much as I'd like to hire the Indians before the chiefs, it's not how things work. And so, but now that Brandon's here, and there are half a dozen people like that who are out in the community who are actually, sleeves rolled up seeing patients. There are 12 different specialty clinics in the health. And the Dell Medical School building that weren't there 2 years ago. I weren't there a year ago. The oldest one just had its first anniversary. That's the musculoskeletal one. And the bipolar disease, women's pelvic disease disorders, untreated depression, cognitive disorders, primary care, occupational medicine, and I'm blocking half of them. But so they weren't there before, and they're now seeing patients. But again, they're still in the ramp up phase. And so up till this point, it was impossible to show a lot of progress because we didn't have a lot of people actually doing the work. But now that the people have been hired and the buildings have been opened and the care systems are being established, then we're more than happy to start showing the data, like a year of the musculoskeletal, 9 months of women's health, 6 months of the bipolar disease clinic, because that's how long they've been open now. So we're frustrated because, I've been here since early 2016. 2 years ago, I was the only person in my department. I got 120 faculty, but half of whom are there are a couple of people in the audience who are teaching and are part of my teaching faculty. It's taken that long just to build, but now it's time to hold our feet to the fire to actually do the work because the people are here now.
Can I add
Yeah,
just
sure.
concretely, because I've been a part of the process, and it's a relatively new process, but I think between our organizations, we have 10 co-hires between community care and Dell. And these are, your Johns Hopkins and your folks who are coming out of great training programs and are mission driven. So we've been able to step up the kind of care that we're giving. At the same time, there are over 200 residents that are now rotating through our system. And if residents train within the system, they're much more likely to work within the system at a point later. So again, we're hoping that this investment, pays off down the line.
Oh, thank you. Vicki, quick question for you. Dr. Butler, has Lone Star considered telehealth to address transportation issues for individual patients instead of waivers for transportation? And I have a second question. Which hospital system do you guys use? Do you use Seton because you're affiliated with the CCC, or does it really matter with your group?
So hospital-wise, it's kind of wherever our patients can get seen and get admitted if they need to do that. We've talked to a couple of hospitalist groups, but nothing's really worked out where they're, on the pediatric side, it's a lot easier than it is on the indigent adult side. So we're still working through some of those. In terms of telehealth, we have considered that. There is a payment issue with how that's done or not done in an FQHC model. That said, we are looking at a couple of ways to potentially do that for certain populations in certain areas of our patients. I mentioned the clinic that's about to be our 19th location. That is one that we're actually starting. It's not in Travis County. It's out west, but it's one that we're actually looking at from the ground up to consider behavioral health services probably as the first jab at that. We're also doing e-consults, which is not telehealth, but it is where our primary care providers can ask questions, like Mark said, of some of the specialists that we're getting in that e-consult network, so that some of the care can be managed on the primary care side before the patient has to try to figure out how to get to a specialist where they may or may not get something because they show up at the specialist's office, they haven't had the labs or the labs expire. A certain amount of time, a lot of times you have to have labs done in before the patient shows up for the appointment. They don't get them done in 30 days or 90 days or whatever, then they have to repeat them, and it was really hard for them to get them the first time. So we have those issues too. Telehealth is an answer for some things, and we are going to take a jab at that. We're just not quite there yet where we want to do it. I think behavioral health is probably going to be the first place we try.
Pete, you're the chair of the Central Health Board. Are the leaders of the city part of the problem, or what's your thoughts interacting with the city council and the mayor and so forth? How do they see the care of the indigent in Austin?
Truly, we're part of the Commissioner's Court. Commissioner's Court, as you well know, is kind of like city council for the county. So we've worked well with both. We work both with the city and the county. And so they're not a problem. They're very much behind what we're doing for the indigent, for our most vulnerable, for our poor, just what everyone else has mentioned. So no, we have no problems with any of the leaders here at the county. That's really my boss as chair of your Central Health Board. The commissioners, the judge, Judge Eckert, those are our bosses, and they really do want to see us succeed and make Mark's job easier for everybody.
What do they see as a big problem in the next 5 years? Is it the rapid growth in East Austin and kind of the lack of clinics over there, or lack of doctors?
Well, certainly the rapid growth of the Upper Crescent of Eastern Austin, Maynard, Elgin. More of our poor people are moving out to that area because it's less expensive to live there. But as Tom Kuplik was one of our previous chairmen and board members, had always told us we needed to expand services, and we're going to do that. We're doing that right now. We're putting clinics in Collins Park, and we're putting clinics out in Del Valley, and Mark is helping us with funding with the Community Care Collaborative. So we're getting there. We're expanding. We're making Tom's wishes come true.
All All right, I know it's getting late. I have time probably for one more question. Does anybody have anything they want to add or any comments?
I'd like to add one more thing.
Yes, sir.
To the previous question about, the $35 million. I know that's a thorn in Mark's side and in my side, and I'm sure in Alan's side and Bill's side. The $35 million that we committed to the school wasn't for bricks and mortar. As a matter of fact, in the many hats that I wore in the last 30 years in this county, one of them was to be treasurer of Prop 1. We told the voters, this money's not going to go for brick and mortar. It's not going to go for salaries. It's about expansion of services. And just like Marcus told you already, and Alan and Bill, we've done that. With the help of people like Carl, Kennedy. We've shortened the time that it's taken the patients to get into the specialist. So we've done that. We're able to use those $35 million for expansion of services. Behavioral health, like Mark talked about the MCOT, that's saving us millions of dollars. They don't have to go to the emergency room. They don't have to go to jail. As you all know, the jail system is our largest provider of behavioral health issues. So the $35 million is, I know it's in the paper all the time, but Tom can tell you as well, that's money well spent for the university and for the school and getting those services that we're going to get from the school.
Thank you.
Thanks, Jeff.
One last question. How do we compare to Dallas and Houston? Anybody? Care of the indigent. We better, worse, catching up, same, different?
So better is hard. I hesitate to say better because then you'll immediately, I'm talking to doctors, you immediately tell me, well, show me the metrics that determine that we're better, and I don't have those readily at hand. In some ways we're different, and part of that's because in a good way and a bad way, the history of healthcare in Travis County is just different than the history of healthcare in Dallas County or in Harris County or Bexar County, if you want to talk about San Antonio. Every one of these big urban counties grew their healthcare systems for the indigent differently. And as a result, there are particular strengths and weaknesses that exist there. Also, the medical communities are different. So we don't, for example, offer transplantation of any sort inside of the MAP program. I guess that there are some individuals in areas where there are transplant centers that actually have access to transplantation. I don't know that with truth. But for a long time, we haven't had a robust transplant program here. We've had the heart transplant program over at SMCA. But we don't do livers here in town. That's not a current capacity of the system. So it's hard to say better or worse. I will tell you, I think that we provide good care, but it could be better, to the indigent in Travis County. But I'll tell you that we do it for a lot less money than they spend in Harris County or in Parkland. So, if you look at Parkland, they made a bet. Their bet was they needed $1 billion plus hospital to continue to care for the indigent in that county. And the good news is that they have a big building that probably costs more. I think it actually costs more than Jerry World down the street. The AT&T Stadium, Parkland cost more than AT&T Stadium to build. The problem is they've got the debt service on that building for the next God knows how many years, that they're going to have to deal with the debt service on that building for years, and that's going to squeeze them in their ability to change and expand care over time. We don't have that here. So the dollars that we have available to actually spend on care. Maybe we don't have as many, but we are also not looking at a healthcare district that is saddled by gigantic amounts of debt. We have a fundamentally healthier financial picture, in my opinion, and we do that with a much lower tax rate than every one of those other urban districts. We have the lowest tax rate for any healthcare district in Texas, and we've always had the lowest tax rate, and we do a lot with a very little amount of money. So in some ways, if you look at value as being the outcomes you obtain over the cost of obtaining them, I would say that we have a high-value system here, in as much as I'm proud of the outcomes we've been able to achieve. I don't think that we've achieved everything we need to, but I'm not unhappy with what we've been able to do, particularly in the last 5 years. And we've done that with very little money compared to these other large urban centers. So that's my take on it. I'm happy to be challenged on that, but I've been doing this for about 5 years, and I came from Houston, was my previous medical environment. So I do have some firsthand knowledge of that medical community and caring for the poor. I worked for the Harris County Hospital District there. And so that's my take on it.
Guys, thank you very much. Panelists, all of y'all, for your time and your insight and your information. I think the goal of all of the medical society and the community is to have a healthier community, and I think that is to be determined, as we talked about, but we know that y'all spend a lot of time, a lot of it free and volunteered. These are unpaid positions that our physicians at Travis County just spend a lot of time committing to our community, and we thank all y'all for doing that. Thanks once again. Are any last comments or questions before we wrap it up? Okay, thank y'all for coming tonight.
Are you playing?